Understanding with my co-guide that anytime an HIV positive patient was admitted to the medicine ward, he would give me a call. Depending upon the patient's symptoms, I would collect samples like blood, CSF, sputum, stool, urine, or even a biopsy. One day I got a call saying that a patient with sepsis had been admitted just then in the medicine ward. History revealed that this was the third such episode of sepsis in this patient. The earlier two had E. coli and Enterococcus as the etiological agents. I collected blood culture samples and also a sputum sample since this patient had complaints of dry persistent cough and occasional chest pain. As was my protocol, I prepared methenamine silver, gram stain, acid fast stain, and also a wet mount of the sputum sample. On microscopy of the wet mount of the sputum sample, I saw something filamentous moving across the field from one corner to the other. This repeated again after a couple of seconds. For a few seconds, I was dumbfounded. What could it be? Suddenly, I remembered studying about strongyloides causing disseminated infections in immunodeficient patients. In immunodeficient patients, filariform larvae develop from the rhabditiform larvae within the GI tract and then they cause autoinfection. On their surfaces, they carry the GI commensals and enter the portal circulation, and these GI commensals then cause bacteremia and sepsis. I immediately informed my guide and co-guide about my microscopic findings. They asked me to go and collect a stool sample immediately. And you won't believe the number of filariform larvae I saw in the stool sample of that patient that day. Immediately, ivermectin was started. The sense of fulfillment and achievement as a microbiologist that I had that day is indescribable. So, this is a classical example of how microbiologists contribute to the treatment of patients.